He just showing the CT scan, and thereafter the case will be proceed. Hand over to sir.
Warm welcome, Dr. Satish Jain from auditorium side. I am Dr. Anil Tukral, along with all the delegates welcoming you. Please begin with the session.
Before this,
Dr. Shalu.
Moving on to the next session, that is functional endoscopic sinus surgery to be performed by Dr. Satish Jain. Moderators are Dr. Tilak Raj, Head of Department, ENT, Safdarjung Hospital, Dr. Rahul Agarwal, Head of Department, Meksh Vishali, and it is to be chaired by Dr. Professor P.K. Rathod, ex-HOD, MAMC, Dr. Pankaj Gupta from Dwarka, and Dr. Anil Arora from Faridabad. So please come and have your chairs.
Yeah. A small introduction of this patient. The patient is a 42-year male coming to the OPD for the nasal obstruction, and he was diagnosed with the bilateral nasal polyposis, and later on CT scan, it appears to be the allergic fungal rhinosinusitis. Now Dr. Satish sir will discuss about the CT. Thank you, sir.
Hello. Hello, good morning.
Tukral sir.
Hello.
Anji, Dr. Anand.
Hello, can you hear me, sir?
Anji, sir.
Good morning, everyone.
Picture is visible, CT picture. We are able to see.
Yes. So, all I'm indebted to the Dr. Anand Gupta and his team and Team Asia for inviting me and giving this opportunity.
Hello.
What an amazing setup it is. Can you hear me, sir?
Sir, your audio is breaking. Just.
Can you hear me better?
I think.
Hello.
Please proceed. Let's see.
Yeah, can you hear me now?
We are.
Okay,
hearing.
so Dr. Gupta has lined up variety of cases, and I am amazed to see the kind of workup he has done. So we are starting with one of the most interesting scenario in otolaryngology, that is endoscopic sinus surgery. This particular patient, as Dr. Gupta has mentioned, has bilateral sinus disease. If I show you the CT scan is one of the most important part of the workup to give you anatomical details. CT is not for the diagnosis most of the time. Yes, it can substantiate your diagnosis. And here are certain characteristic findings on CT scan to give you regarding the particular endotype of CRS, chronic rhinosinusitis. So by and large, once it comes to order a CT scan, we must order submillimetric axial section. See this is 1.3 mm sections. On the left side you can see shot in axial plane. We should have CT scan both in bone and soft tissue components. This is bone window setting. This is axial. Through a software to give you anatomical details, we can convert into 3D, three-dimensional axial coronal sagittal pictures to give you anatomical details in each and every plane. This is classic of a DICOM to see the CT scan. The role of CT scan is to give you anatomical details in every plane. We know in sinus surgeries, the threshold of safety is very low. Even a submillimetric disorientation can lead to a major complication because sinuses are surrounded by orbit all the way and the skull base above. So we have to be very, very careful, and the CT scan gives you, three-dimensional anatomy of the given area where we are going to operate. So coronal picture gives you most of the time the information. What we all need is the bony details. Can you see the 3D CT scan on screen?
Yes, we can see.
Now, if we see quickly from anterior to posterior on coronal, if I show you coronal directly, see this. The most anterior picture shows pneumatization of the frontal bone with opacification in the right side of the frontal sinus and the intersinus septum. And below is the beak. This is beak. Now, as you go behind, see both the frontal sinuses with
We have
little
lost the
opacity
3D
on the left side as well. And the cell, the initial or the first cell which is appearing. First cell is the intersinus septal cell. See this? This is pneumatizing the intersinus septum. This is intersinus septum and this is pneumatizing the intersinus septum. This is the first cell, and if you follow this, this is draining on the right side. See the drainage pathway of this cell.
Yes, we can see.
So while we do the frontal sinus work, we have to ensure that this cell is draining well in the frontal sinus on the right side. Can you see very clear?
Yes, yes, we can see. Yes, we can see.
This is the beak. About the level of the beak is the frontal sinus. Now, as we go behind, now beak has left. Beak has gone. See the maxillary sinus has started appearing. We are far behind now. See, far behind.
Yes.
And this structure which is appearing like a frontal sinus going above the orbit is actually supraorbital cell.
Right.
So supraorbital cell is a posterior structure to the frontal sinus. See, anteriorly this was frontal sinus.
Right.
Now as we go behind, this is supraorbital cell. How you can confirm this? You can confirm this on sagittal plane. See, on sagittal plane, if I take my cursor here, this is frontal sinus. See this frontal sinus on the sagittal part.
Yes.
Now, if I go behind and push my cursor into it, can you see this cell behind the frontal sinus on the sagittal plane?
Yes, yes. We can see.
This is supraorbital cell. Okay? So frontal sinus is anteriorly, supraorbital is behind. That we must know to relate this anatomy in between these two structures, the supraorbital behind. So once you see the frontal sinus anteriorly, just underneath the beak, see, when we come from anterior to posterior, from here, this is the thick beak, and when we follow the beak, where the beak ends is the frontal sinus. Supraorbital cell is always behind the frontal sinus. This relationship is very important, otherwise surgeon may end up opening the supraorbital cell considering it as a frontal sinus. And that is a blunder. So we can avoid this by knowing this three-dimensional anatomy of the paranasal sinuses. Then the positive findings is ethmoids, maxillary sinuses full of opacity, more opacity on the right side as compared to the left one. And as we go behind, you know, to see the big post-ethmoid cells, and behind are the frontal sinuses looking clear,
Sphenoid.
not very massively diseased by any mucosal hypertrophy or anything. Now coming to the differential diagnosis, if I see the soft tissue window now, the things are interesting. See, in this soft tissue window, what we see, the same disease with heterogeneous densities. Can you see these densities?
Yes, we can see.
These are basically representing the fungus and the eosinophilic material around the fungus. And that is classical of allergic fungal rhinosinusitis. So, this is a different variant of, one of the variants of, common variant of CRS, that is AFRS. CRS is a complex disease, has various endotypes. Every endotype has a different underlying pathophysiology, prognosis and outcome. See, this AFRS has a different pathophysiology. Here, this is, the pathophysiology is purely allergic. The person is allergic to fungus, and when during inhalation fungus happens to trap into the paranasal sinus, the eosinophilic activity came into place to combat the fungus, and that's how the picture of AFRS develops. Another interesting finding is a little deviation on the right side. We will see if it hampers our visualization, obstructs our visualization of the paranasal sinus, or nasal cavity airway, then we'll correct it endoscopically at the same time. It depends upon the endoscopic picture. If required, we'll not think twice before correcting it, we'll correct it. So, in this particular patient, we have a right sided frontal sinus disease, intersinus septal cell, supraorbital cell, massively affected the ethmoids and the maxillary sinuses, sinus maxillary on both sides, and relatively the posterior ethmoids and the sphenoids are spared of disease. So the goal is to remove this antigen. This fungus is antigen. The goal of sinus surgery is three-pronged in this scenario. First is to remove this all fungal material so that the further antigenic activity and the eosinophilic activity can be stopped. Number two, give wide openings to the paranasal sinuses, all our sinuses which are affected, so that the ventilation and the drainage pathway is established and the further, surveillance can be made endoscopically for life. And third and the most important is to give access to the topical steroids for the future. This is purely allergic disease. Allergy means it requires steroids for treatment. The role of surgery is to remove this antigen and establish ventilation and drainage. And since it is a medical disease, allergy, surgery is not the answer for medical disease. For this medical disease to prevent relapses, you have to give topical steroid. Steroids for life. And we cannot give oral steroids for life because of their adverse effects. So the topical is the best choice without systemic side effects. And this sinus surgery gives opportunity for the topicals to penetrate into the depth of the paranasal sinus mucosa. So the goal of sinus surgery here is three-pronged. Removal of the fungus, the antigen, establishing the ventilation, drainage of the sinuses by opening them widely, their ostia, and third, giving access to the topical steroids. Any questions, sir, before we move on to the case? The case is
Hello.
ready, I suppose.
Good morning, Dr. Satish. I am Dr. Rathore from Maulana Azad.
Sir, good morning.
Good morning. So, preoperative preparation, just few words for is it conventional CRS or AFRS you prepare in a different way, preoperative preparation?
Yeah, so little different. Every endotype has to be dealt with little differently. So in AFRS, since it is purely allergic disease, the role of, even in the preparation part, steroids. No role of antibiotics or anything. So in preparation, we tend to give or start steroids a couple of days or a week before surgery to reduce the inflammation. See, the inflammation is purely because of the allergic reaction. So in this surgery, this is a surgery of landmarks. At every point, you have to discover a new landmark to prevent complications. And that is affected by the more and more ongoing bleeding because of the ongoing inflammation. And in order to reduce the inflammation and the overall bleeding, you have to prepare the case preoperatively to reduce the inflammation. And here in AFRS, since the core cause of inflammation is allergy, eosinophilia, so the core treatment of preparation is steroids. Why I am saying this, according to your question, had this been a different variant, we would not rely solely on the steroids. Here, the high dose of steroids solely is the answer for preparation even to reduce the inflammation and the overall bleeding. Suppose that the case would have been a different one with a non-eosinophilic disease like non-polypoidal sinusitis, cystic fibrosis or any other, we would not focus on steroids, rather antibiotics more and more for preparation to reduce the inflammation. Because that the cause of, the mucosal inflammation is infection. So we have to understand in this particular CRS, the core treatment pre-operatively, during preparation and post-operatively as well. It is steroids. And that's the only variant where in the post-operative period, we are biased to give oral steroids for a couple of weeks. In spite of starting topical steroids immediately after surgery, a day or two after surgery, still we offer oral steroids to contain the high-grade inflammation because of the fungal allergy for a couple of weeks. So this is quite different I would say, from the regular CRS. Any other questions, sir? Hello?
No, you can proceed, Dr. Satish.
Yeah, and we can continue this discussion intraoperatively also. Please feel free to interrupt any point of time.
हाँ दिखा दिया.
I welcome our medical superintendent of Maringo Asia Hospital, Colonel Dr. Navneet Chabra. He has been highly instrumental in organizing all this event. And can I connect in the OT?
Yes, sir, you are connected to OT.
Please show your faces. Dr. Gaurav,
मेरा फोन निकाल
we have time.
साइलेंट कर देना.
Let's introduce you.
8 नंबर दे दो.
This is our OT.
ये चालू है अब.
Preparations going on. Dr. Gaurav, please come forward before the camera.
Morning, sir.
Good morning. Hi, OT team. Hello, everyone. Dr. Gaurav?
Yes, sir.
Yes. Patient is ready?
Yes, sir.
Want to speak something? We have time.
And what about the pulse rate?
Sir, pulse rate will be between 65 to 70. That is good enough for me.
Okay, thank you, Dr. Gaurav. So you are basically talking of an hypotensive anesthesia.
Yes, sir.
Disconnected. This picture going.
Yes,
Hello?
yes, the picture is coming.
Yes, picture
Dr.
is
Satish,
good.
you can
Yes.
proceed.
Okay, so this is the first endoscopic picture before any intraoperative preparation. Can you see this?
Yes, we can.
Yes, preoperatively this patient has been prepared with good course of steroids. So this intraoperative preparation is again very important, and it is again multi-pronged. The aim is same, to reduce the inflammation, to reduce the overall bleeding. And here I am indebted to our anesthesiologists here for giving this wonderful field. And there are certain parameters we request our anesthesiologists to give us a good field, and one of them is the reduced heart rate. In this particular patient, we have patients of JNA as well today, where the principal source of bleeding is arterial. And in those scenarios where the arterial bleeding is the principal source, we request our anesthesiologists to give us hypotensive anesthesia. In this surgery, what we have realized over the period of time, the principal source of bleeding is capillary, not significant arterial one, and the reduced cardiac output is the key to reduce the bleeding, and that is achieved by the reduced heart rate. And here we are grateful to him for giving us heart rate below 70. We target our heart rate around 16 most of the times to reduce the cardiac output more and more, without more and more emphasizing on hypotensive anesthesia in labile patients. This is a benign disease. Like this patient had OS and all that, they have hidden cardiac component many a times, and we never, force our anesthesiologists to give us hypotensive anesthesia more and more. A reduced cardiac output with local preparation, what I am doing, using saline adrenaline soaked in these marrow cell pieces. We divide marrow cell, 2 marrow cell in 8 to 10 different size pieces, soaked in saline adrenaline. In this particular patient, we have 1:3 combination, and then we use topical with a combination of pre-operative preparation with steroids, intraoperative anesthesiologist assistance, and this intraoperative topical preparation. All together done, if properly, your surgical field can be achieved same like we achieve after infiltration. So here we are achieving without infiltration. The reason is this infiltration can sometimes be, dreaded with complications. We have witnessed, we have seen in literature, if this adrenaline happens to enter into the systemic circulation, can have deleterious cardiovascular consequences in labile patients. So why to subject such benign disease patients to such complication unnecessarily when we can achieve the same surgical field with the topical preparation only? So we are of the opinion not to use any infiltration in any nasal surgery whatsoever it is, as this is richly vascularized area. Can you see the capillaries, the bunch of capillaries, the vessels everywhere? Can you see this?
Yes, we can see.
So we tend to avoid infiltration in any nasal surgery, and we get or achieve the same surgical field without topical preparation. See, this is topical. Marrow cell has an added advantage over the gauze pieces. It is so soft. It can be introduced in any narrow space. It swells up and opens up the space. This is absolutely atraumatic to the mucosa. So there are various advantages of the marrow cell why we use it. Now another important thing which we always emphasize in such scenarios is the nasal septum. Look at the high deviation of the nasal septum. Can you?
Yes, we can.
Oh, this is very, very interesting. This high deviation we have witnessed, if not corrected, can be the single most cause of entire failure of the entire surgical exercise. This non-correction of high deviation, the reason being, suppose after decongestion, if I try to use this narrow space for my instrumentation again and again, and with experience you can carry out the surgery as well. But what happens? Due to narrow area and instrumentation again and again can invite raw areas on opposing surfaces and can invite ultimately lead to synechias. This surgery, I told you, my third and the most important goal for the surgery is to give access to the topical medication. If synechia happens to occur, that goal is, lost, completely lost, and can result into failure. If the steroids do not reach in the depth of the paranasal sinuses after this, this is bound to come back. You cannot give oral steroids for long because of their adverse effects. So if this high deviation is not corrected, this is almost always a problem inviting synechia and then ultimate failure. So this is important. I mentioned during CT scans that this decision is on the table whether or not to correct the high deviation. And this can be simply corrected in no time endoscopically as well. And this is I am going to demonstrate as well. Again, without infiltration. No infiltration in the nose to give tough time to the anesthesiologist to where the BP can shoot if the adrenaline goes into the systemic circulation. So we get the same surgical field. See, in spite of the topical adrenaline, our pulse is stabilized at 60, you can see above. The reason is simple single application of the topical adrenaline decongest the capillaries to prevent systemic absorption. Whatsoever the topical I am using, this is not being, absorbed systematically, and this is not affecting the blood pressure or heart rate or any other parameter. No adrenaline in the circulation to affect anything. At the same time, at this being an infiltration can do anything. If goes in the systemic circulation, the cardiac events have been witnessed, documented, fatal and unfortunate. So that in such benign disease should be avoided if you achieve the same field by other means. Now, see now how the narrow space on this side, particularly high up. Can you see this? Do you agree with me to correct this high deviation?
Yes, it should be corrected.
Without correcting this, one cannot give or expect a good outcome in sinus surgery, as your access to the topical is going to be compromised. Not for the intraoperative purpose. I can little bit fracture it, I can negotiate my instrument through the narrow space and ultimately carry out sinus surgery. But this is going to be a tough time in the post-operative period and failure. So here, what I will do, suction periods. First, I will correct this limited high deviation, limited septoplasty. See this again endoscopically. in this patient, I am not doing septoplasty to improve the nasal airway. See, nasal airway is reasonably good. See this?
Yeah.
The septoplasty, this limited septoplasty is being carried out to facilitate instrumentation for sinus surgery, not for
Airway.
airway. So what I will do, I am not giving the classical, incisions. My septal deviation is behind and above. See this here.
Yeah.
Similarly, my incision on the opposite side are to be different. See this?
Yeah.
Far behind and above. I am not disturbing the entire septum and its strength. Just a limited septoplasty, the incision is more than 2 centimeter behind. See this?
Yes.
And limited above. Section नहीं चल रहा है. See this? I am in the right plane. No infiltration was given. Here, if you want to facilitate this dissection further, you can use hydrodissection by injecting normal saline into the plane. There is no harm in doing that, depending upon your experience and your comfort. See the deviated part of the septum. Can you see this?
Yeah.
So, in order to improve further, we can do variety of septoplasties. Sometime breaking the spring only, sometime removing the or breaking the bony cartilaginous junction, or sometime removing a part of it even without any harm. See, going to the opposite side.
Yes.
Now I am raising the flap on the opposite side in the same plane. Can you see?
Yes.
See, this is the deviated septum. See this?
Yeah.
Giving problem. So just be rakhna. Sharp instrument. See this? Not to give any pull to pull the septum or separate it from superiorly. Just sharp punch. Elevate the flap. A sharp punch. Superiorly, we have ample of space. We have to leave adequate septal strength, septal margin to prevent saddle deformity. I have not gone very high up. We have adequate superior margins. I am focusing only and only to remove the deviated ones. Can you see now?
Yeah.
Opposite side. See the difference. That was a classification given by Shatki earlier. Not very popular, but if you consider it is very useful. I am able to see my turbinate now well. Can you see?
Yes.
Earlier, I was only able to see this lateral wall, not even a glimpse of turbinate. Can you see?
Now, yes, we can see the turbinate that is thinned out.
In Shatki's classification, if you are able to see medial to the turbinate, that is level 1 which you want to have. If you are able to see a part of the glimpse of the turbinate, level 2, and not a glimpse of turbinate at all, and the septum is so deviated, you are only able to see the lateral wall, that is grade 3, and that requires a definite correction. See this? Limited correction has enabled us in the simplest manner. So this is limited septoplasty. You don't need to remove everything. And see, our goal of gaining the good access is achieved. Are you happy with it?
Yeah.
Say this. The nasal cavity on the right side and the access we have achieved. Absolutely, to the goal what we wanted. So, giving extra 2-3 minutes can make the wonders in terms of overall results. Can you see this? Otherwise, going through the narrow space and giving synechia and making your life hard, and the patients as well, is something which is one should always avoid. Now, I will leave it here. My opposite nasal cavity is good, and I will not even, stitch this. This will fall back in place. See this?
Yeah.
And we have a good adequate airway on the opposite side as well. So that was the septoplasty. Now, as far as the sinus surgery is concerned on this side, I told you the sinus surgery is the surgery of landmarks. And in this, again, the landmarks are distorted because of the massive disease behind in the maxillary and the ethmoid. Why distorted? See the uncinate process. Ballooned out. Can you see? Yes. What you see otherwise in the middle meatus. Again, I mentioned here the surgical field. Look at the parameter. I always look at the pulse exactly 60. Hats off to the anesthesiologist here. This is what we always aim at, and there is hardly any bleeding you can see, and there is no infiltration. What else you want? See this. What you see, this is deformed uncinate. Can you see this? This uncinate is ballooned out like this because of the massive disease behind. Disease pressure. So this massive disease pressure does a lot of things in the middle meatus which you can observe. Number one, distorted uncinate, ballooned out uncinate. Number two, compressed middle turbinate, and this is compressed with high division as well. See how middle turbinate is so thin and many times becomes floppy. And the third one, because of this massive disease, the compressed and the atrophic bulla. All these things, if you are not careful, can land you in complication. So now we know this is uncinate. Why this is uncinate? See, in the entire lateral nasal wall, that's the only mobile structure. Only mobile structure is the uncinate, rest are all fixed. So here, there are many ways to remove the uncinate. Simplest way, go in the middle meatus, engage your reverse biting, turn it little down and bite through. Bite through it, come anteriorly until you reach the hard bone, and then you are not supposed to bite it through. Once you reach the hard bone, that is the nasolacrimal duct immediately anterior to it, and you have to realize and stop. See now, this uncinate is divided into the upper part, vertical, and the lower horizontal. This is horizontal going behind to the perpendicular plate of the palatine bone most of the time. And now I am fracturing the lower uncinate. And see, this is all maxillary sinus. Very clear? Yeah. And I can use my shaver here, microdebrider, to prevent mucosal stripping and taking a part of the upper part of the uncinate, and this is all fungus. See this? Which we realize on CT scan through the heterogeneous hyperdensities. This is because of the allergic reaction, and this is non-invasive. There are a variety of fungal diseases, and this is classically non-invasive fungus. How is the surgical field, sir? This is without infiltration. what you all need is a good high power suction as well. And in fungal disease, many times we use hydrodebrider to flush away the fungus. Suction. See, this fungus is non-invasive to the underlying mucosa. Non-invasive fungus means the fungus is not invading the mucosa and there is no role of antifungal. Invasive fungus, here the primary role in non-invasive is surgery to remove this fungal antigen and the eosinophilic material. In invasive fungus, it invades. The primary role is medical, antifungal. So we have to understand this fact, and by a good imaging, you can very well differentiate into variety of invasive and non-invasive fungal diseases. This cheesy material, sometimes so frustrating to remove, is classical of allergic fungal disease. This is all fungus wash. Look like this, what? The various ways to deal with this inspissated fungus material. High power suction, obviously you can see a good high power suction. Irrigation to flush it off. Then instrumentation to engage and remove it. And then hydrodebrider. There are many ways. The classic thing is it doesn't invade the mucosa. This mucosal reaction is because of the allergic reaction. Once you remove the fungus, establish the ventilation and drainage, and start introducing the steroids into the cavity, all this reverts back to normal. So you don't have to, deal with this mucosa aggressively. This is going to come back to normal once you restore the sinus physiology. And see what happens. In between the mucosal folds, the fungus happens to get trapped and give you a tough time. So be careful, decongest the mucosa in between and the mucosal folds, so you don't miss out any fungus trapped in between. Give me debrider. See the hypertrophic mucosa everywhere. You can reduce that. You can reduce the mucosal fold. Suction, flush कर. See, reduce the mucosal folds. Look, ball pro. Still there is fungus. Ball problem. Now we'll use some instrument to engage this fungus. And ball probe is one of them. Engage and dislodge this fungus as a whole. See this? I am not trying to break it, I am trying to bring it out as a whole. See now the entire fungus is coming out. So this is something which requires a little bit of time. This is frustrating, but obviously you can't help it. Wash. See this coming as a whole. Can you see much better picture now? Now, Merosel. Yes, yes. This mucosa, once ventilation drainage is re-established, once the inflammation is contained by removing this antigen and consequently the eosinophilic reaction, and you start introducing steroids, this mucosa comes back to normal. See now what I am doing, very important. This fungus can be trapped within the mucosal folds. So I am using this adrenaline soaked Merosel to decongest the mucosa, to flatten the mucosa, to flatten the mucosal folds, to remove any trapped fungus in between. See this small pieces. Yes, yes, we will. Wash is always there, intermittent. I will use my 70° also to visualize everything. Wash. Hydrodebrider is one technique we always use during allergic fungal sinusitis. That gives a water jet, a pressure jet, 360° in direction. Now give me 70°. So first time I am changing to the 70 now. You see the big maxillary sinus, which was otherwise full of fungus earlier. And now see the maxillary and see still little bit of see this thick mucosa and in between the mucosal folds. That is how this fungus. See, if you leave the fungus behind, it can further carry the inflammatory momentum. Sometimes, if you are not very sure about the anterior most part, or you are unable to reach out there in spite of the best long curve instrument, then we do make a second port. I will show you. See this? Still there is remnant fungus. There is a lot of edematous mucosa anteriorly. If we leave like this, we can leave the fungus material contained in it. Can you see this? So here, to make it more effective, what I am going to do is making an So now I am making another port here to introduce my instrument, my microdebrider from anteriorly in the sublabial region. This is to show you how most anterior fungus can be dealt with, or most anterior maxillary sinus disease is dealt with. So here in the mid pupillary line, see the pupil here above, in the mid pupillary line where the anterior wall of the maxillary sinus is the most thin part, I would say, in the mid pupillary line, staying a centimeter above the gingivobuccal margin here. See, the bone is very thin and I am inside. Let me show you with my camera. Can you see my trocar which has gone inside? Yes. Now what I will do, 70. I will remove both trocar and cannula and introduce my red 40 microdebrider through it, which I can somersault 360 degree to visualize each and every nook and corner of the maxillary sinus. See now, I am removing both trocar and cannula, both. And through the same port, I have introduced my I have introduced my microdebrider. See this? Yeah. Now, see the additional port I have now to remove all these mucosal folds and the fungus more effectively, which is sometimes not possible with your regular instruments. And beauty of this is, I am using red 40, you can use 360 degree in every nook and core of the maxillary sinus. See till anterior wall. So this way you can more effectively deal with the most anterior disease. Can you see now? Yeah. Now give me wash. See, this is red 40. See now I'm flushing this region. Flushing and flushing, and see the maxillary sinus ultra clear now without damaging the mucosa. Can you see? And give me a pack, and I will leave another decongestant pack of the marrow cell to see later. Okay? This is how one can deal with the allergic fungal disease. So you have to ensure by all means, see the mucosal condition, it is so good, so healthy. It is just edematous because of the ongoing inflammation in the vicinity. That's it. Okay? So I am with the 70 only now, looking up. See this? Using 70 only so that I can look up and deal with the frontal sinus in the beginning only. See this? This is your turbinate. See how floppy it is, I told you, because it is compressed between the disease and the septum. See, this is the remnant of the uncinate. This upper part of the uncinate we remove is, when you remove this, you are closest to the lateral wall of the entire corridor, that is lamina papyracea. This is the closest to the orbit. This is lamina papyracea here. So with 70 you can find your lateral limit of the entire sinus surgery corridor in no time. Here, this is your bulla which is compressed. See this? Not very prominent, otherwise a big cell it is. Now, I am removing the most superior part of the uncinate. See this? I am focusing more and more up at this point. For junior colleagues who are finding difficulty in frontal sinus, I am taking you to the most simplified approach to the frontal sinus now. In no time, in any given difficult sinus anatomy, you can reach out in frontal sinus in no time, which is otherwise considered to be the most difficult one. See this? Again, you can use in between those marrow cell packs soaked in adrenaline to improve your surgical field. Same. See this? Without infiltrating. Without infiltrating. That's your middle turbinate. This is floppy because of the compression from both sides because of disease and the high deviation. Now, and see this bulla is almost atrophic. More the significant disease in the middle meatus, more the bulla will be compressed, more the uncinate will be distorted, and more the middle turbinate will be compressed. Now at this point, how to look at the frontal sinus so easily? There are, why we are frightened with the frontal sinus? Because of the fear of complication, because of the close proximity of the frontal sinus to the orbit, to the skull base, and sometimes we are always, frightened with the anterior ethmoidal artery. Believe me, if at this point, if you look up with the 70-degree, I suggest you a couple of landmarks. You will never land up in complication and your all fear will go off. Why? We have already seen the lamina papracia here. Keeping this in view with the 70-degree and not crossing beyond laterally always will preserve your orbit. Okay? This turbinate, this upper part of the turbinate goes behind and above to get attached to the cribriform plate. If you follow your turbinate and stay lateral to it, you are practically away from the skull base. You can avoid unnecessarily unwanted skull base entry. Okay? And bulla. This bulla most of the time reaches to the skull base. And anterior ethmoidal artery runs along the skull base behind the bulla. So as long as you keep this bulla intact, your anterior ethmoidal artery is behind. And with 70-degree, your trajectory is anteriorly pointing. See this? We are pointing more and more anteriorly, not behind. Anterior ethmoidal artery is a structure which is running behind, almost 2 centimeters from the edge of the beak. Okay? Now at this point, looking at all the 3 structures, again, this lamina laterally I am not going to breach, this turbinate medially I am not going to breach. And see this, where this turbinate is attached to. This is the frontal process of maxilla. This is leading to the beak. This thickest bone here is the beak. Staying between the lateral and medial limit, if I follow the beak, I showed on CT scan how you follow the beak. See, in between these 2 structures, if I follow the beak, see in between these 2 structures, neither crossing medially nor laterally, I am just following this thick bone of beak. See, this is the thickest bone in this region. Follow it and go behind where the beak ends. See, my beak is ending, can you see? Where the beak ends is the frontal sinus. That's the frontal sinus. In the most, I would say, simplest manner, any junior guy, junior colleague, not well versed with too much of frontal sinus surgery can easily open up the frontal sinus, and that too in the beginning. Can you see the frontal sinus high up? See the margin of the beak. That is important. Yes, sir. Yes. Let me decongest and show you again the beak. See, the reason of using 70 degrees to keep my lateral and medial limit in view. So I don't cross them and don't get into complications. As long as I stay lateral to this turbinate, I am not going to breach the skull base. As long as I don't cross lateral to this lamina, I am not going to breach into the orbit. Staying in between and this thick bone, look at this again. Finding beak is so easy. This is axilla, one can find easily. This is beak, thick bone. See this thick bone? And where this thick bone is ending is the frontal. There cannot be any simple way. This is just exploiting the nature's anatomy. Why? What? Pardon? Yeah, if it is over projecting, I can punch it out. I will show you. Yeah, if it is over projecting, we can punch it out. See now, I am behind the beak. Can you see? Band hai yaar. Clogged. Let me show you. Widen the frontal. Now, once you are dealing with the frontal, see this floppy turbinate. We'll do it something to it later. I am not trimming or doing anything to the turbinate because this is serving as a great landmark right now. Whatever you do with the turbinate, we'll do later on. See now, I will widen the frontal, and once you are in the frontal sinus, you have to widen it to the limits. See the fungal disease? See the mucosa? Yes. Yes. If it is overpacked, sometimes you have a minimal disease, then is a different issue. Like in maxillary, we saw it was so overpacked. See now, we have widened the frontal. Now here the goal in the frontal sinus surgery is to widen to the limits. Wash. Now I will give it a wash inside the frontal to flush it out. See this? Inside to flush it out. No patla de. See this? More and more fungus I am flushing out. More and more fungus. See, I am going there, rightly there, and flush it out. Yes, now. See the same cheesy material. Strong. You have to change various from fine to the wide bore suction tip every time depending upon the need. And this is a strong suction now. See this?
Yeah.
The value of strong suction brings out in one piece. Wash. So, see this is axilla. Underneath the axilla is the beak. One can easily find this thick bone. And underneath the beak is the. In whatsoever the anatomical variation, if you stay between medial and lateral limit, this is going to remain same. As simple as that. 120. Yes, yes, please. Yes, I will, if you want. This has been a age-old strategy. This used to work and very useful in the era when 70-degree was not popular. And you would always be, in uncertainty whether we entered into frontal or not. In this era with 70, when you look directly in the depth of the frontal, this is hardly any value, but still I will show you. First time, what I'm doing is widening. See this?
Yeah.
This widening for two reasons. Number one, to the limit so no fibrosis happens and narrow the sinuses later on. Number two, introduce more and more steroids effectively. You will see the wide frontal sinus inside very soon. See the big frontal sinus?
Yeah.
See the big frontal sinus. Now to further, the punch. If you want to see, this is over projecting beak, somebody has asked me. See this? What I can use, this is my favorite Karl Storz articulated punch. And punch out this beak. So easily. This is articulated punch from Karl Storz. This is 9 articulations. And you can reach out. If you want more further anteriorly, it has 16 articulation as well. See now?
Yeah.
Wash. Still our frontal sinus work is not complete. I showed certain structures, certain cells in relation to the frontal sinus earlier. Yes. And intersinus. See, the frontal is very clear now.
Right.
See the difference between the cell and the sinus. Now, I am using a different blade. See, we have seen our anterior wall, anterior limit. This is the beak. Can you see?
Right.
Medial limit, lateral limit, and posterior limit is the skull base. See this disease, mucosal hypertrophy. Now working at the skull base is always a challenge. So what I am using, my reverse blade. So-called adenoid blade, which never used for adenoid, never recommend, because now with the 70 degrees, this reverse facing blade has become front facing. Can you see?
Right.
Without pressing on the skull base, I am working in the lumen, allowing the polyps to jump into it. See? See, not forcing it anywhere. Now see the frontal much better. Can you see very clear?
Yes.
Now, let me show you further. Remember, I am not pressing it on the skull base like anything. I am using in the lumen whatever loose polyp or tissue or cell can come into it rather than see the fungus. I am not forcibly placing it anywhere. Can you see this? See this? This is flushing the skull base, defining your skull base. Much better. Can you see? Now, further cells. Patla de. वो अंदर करा दिया ना? Yeah. See the fungal material I have taken. This is your frontal sinus there. most anteriorly medially I communicated with the intersinus cell here. That is the intersinus septal cell which I have communicated. See that? Give me 120 or better. Already see the frontal sinus there and the intersinus septal cell medially. I already evacuated the material from there. Let me show you. Here medially. Can you see now?
Yeah.
Let me widen it little bit. We must know the relationship of all cells to the frontal sinus. This is medial one and the most anterior of all paranasal sinus cells. See, very clear? Already cell is clear and the mucosa is visible. That is intersinus septal cell. Sometimes this cell is too big and narrow the frontal sinus opening from medially. Now, where is the supraorbital cell? I told you the frontal sinus is here, above, and supraorbital cell is behind. Supraorbital cell is behind and going above the orbit. See this? My frontal sinus is way there anteriorly. Can you see?
Yeah.
And this behind and going above the orbit laterally. This is your. So the medial cell was intersinus septal cell, lateral cell was supraorbital cell, but frontal sinus is well anteriorly. So for frontal sinus anatomy, whatsoever the cell is, just follow the beak and open the frontal sinus from that approach. Any cellularity in this region is not going to challenge the frontal sinus. Now, this supraorbital cell sometimes is so big that it narrows, say this cell, it narrows the frontal sinus drainage from laterally. If intersinus septal cell is too big, that narrows the drainage from medially. See this cell? Far laterally. If it is too big, sometimes what you can do is remove the party wall between two and make it a part of frontal sinus. See this? Like this. Give me reverse. So these are all strategies according to the demand, according to the anatomy. Can you see all very well?
Yes, we can see.
So frontal sinus work is always interesting. All depends upon your three-dimensional CT scan understanding, otherwise you can miss out everything. This I would not appreciate the way I am had I not read the CT scan carefully. See my lateral limit lamina all the way. Now once you have seen the supraorbital cell, you have to be careful. Immediately caudal to the supraorbital cell is the anterethmoidal artery. That's a great landmark. This is my artery. Always caudal to the supraorbital cell. Means anteriorly frontal sinus, behind the supraorbital, and behind the supraorbital is going to be the vessel. So don't get frightened from the beginning with the vessel. See this, I told you, this is your beak, edge of the beak. From edge of the beak to the anterethmoidal artery is over 2 centimeters. So with 70 degree when you are directing anteriorly, don't frighten yourself all the time with the anterethmoidal artery. That is far behind the structure. Far behind means behind the supraorbital cell. 2 centimeters from the beak. Not so. Now see my vessel, sometime it is in mesentery. You have to be careful. See my skull base blade. All the time working on the skull base without giving any pressure anywhere. Can you see the vessel running in the middle? Yes. Now give me wash, give me decongestant to see everything. Our job for the 70 degree with the anterior works and frontal sinus, all these cells is over. I have not done to this floppy turbinate anything so far because we were using it as a landmark. Done. Done. Now I will change to 0 degree. Lateral portion of the? I didn't get your point. Which cell? Frontal? Which frontal cell? Laterally? You can with a 70 degree. I have changed to 0 degree now. In the frontal sinus? We'll wash it if it is. Give me 70 degree again. At the end you have to wash. Okay. In the frontal sinus. That is mucosa, not fungus. A little hypertrophied mucosa. Can you see? Hello?
Yes, sir. Yes, sir.
That is mucosa. No worries, it will settle down. That is not fungus, it's hypertrophic mucosa. And will flush at the end anyway. Now back to 0 degree. So now last part left is, see, this patient doesn't have any post-ethmoidal and the sphenoidal disease. So I'm not going to unnecessarily go and dissect over there. We'll do a little bit of the remaining ethmoidectomy with the 0 degree now. See the floppy turbinate. See this floppy turbinate?
Yeah.
And there are many ways to deal with it. You can Bolgerize it, you can do partial resection, sharp resection, or you can remove this only hypermobile floppy anterior part. The goal is it should not fall back in the ethmoidal cavity in future. Got my point? If it falls in the ethmoidal cavity and blocks it, your purpose is defeated. Many a times we settle with a debride. Now see, it is not going to fall. See this?
Right.
All floppy part is taken care of. This is your anterethmoidal artery. See this turbinate is now not going to fall. See this?
Yeah.
This is remaining anterethmoid cells. And I can flush them with the orbit. See this? Medial wall, inferior wall. Sometimes you miss a hidden Heller cell, you have to be careful. Polypoidal mucosa, you can settle down a little bit. And this is all about the anterethmoidectomy. Now, if you wish to go behind, I make a medial opening, widen it. See the superior turbinate behind. Can you? This is the superior turbinate. This is the post-ethmoid window. I can, if you want, I can do it. See this, just to show you, so all clear behind. So I am not going to the sphenoid unnecessarily disturbing the natural anatomy. See, it is all pretty clear. See, the goal is to combat the inflammatory process and to introduce the steroids. Once you remove the source and introduce, it's not that the surgery done and you stop treatment. The treatment, medical treatment starts after surgery, that is topical steroid. Yes, exactly. So once you start introducing the topical steroid, nothing is required to be done. See the, yes, see the sphenoid ostium, yes, from here, see this? You can do further to open up the sphenoid and see well preserved mucosa, nothing is required to be done unnecessarily, it is done. ले रहे बस हो गए. See this? This is about the full house surgery on this side. You can say I left a little bit of the posterior work since it was normal, but rest whatever done, wide openings. See this?
Yes.
Now for next 10 minutes, one should keep flushing, flushing and flushing. On the opposite side, only the maxillary sinus work is required to be done, which I am not showing, as the other case is ready. Say this. See, after this septal correction, which has made our life so easy, could you see? Our instrumentation, it made so easy. And more importantly, introduction of topical steroid would be much easier after this limited septal correction. Agreed? See now, in your OPD, you put your 0 degree and you can see all sinuses there, right up to the frontal there. See that? That's it?
Dr. Satish, one question.
Yes, please.
Two words for conventional. What is balloon?
Sir, we have to understand the physiology of the sinuses. You have to wide open the sinus, not only for once, for life, to introduce topical steroids there. Balloons cannot serve that purpose. It's a joke. For a very, very limited single sinus disease, when there is acute sort of empyema, and to drain that, you can widen the sinus temporarily with the balloon and drain it. That's it. That can work. For that, in 5 minutes, you can do a regular sinus work as well, rather than unnecessarily wasting time and money for balloon. So, practically, scientifically, I don't see any single best reason of using balloon in life. That is, the business, marketing and all those things are different, but the science is different.